well over a year and a half ago. I can't even believe it. Somebody mentioned it, and I was like, no, we've only been doing it for a couple of months. But yeah, time flies when you're in the middle of a worldwide pandemic. But we're super glad that we can be here for you. Now, people who watch every single Monday at 2 Central, 3 Eastern know what I'm going to say. I'm going to tell everybody to sign up for NAMI Tennessee's email list so you can find out the great things that NAMI Tennessee is doing, things like legislative advocacy, courses, classes, and of course, this. Right? Don't you want to know what's coming up every Monday? We're going to tell you the week before. You'll be like, it's like the red carpet except in email form. I think maybe I've oversold it, but please sign up at namitn.org so that you can keep in touch with NAMI Tennessee. All right, enough about that. Let's bring on our super cool guest. Hello and welcome to the show. Can you introduce yourself?
Yes, Gabe, I'm Meg Chisholm, Margaret Chisholm, MD. I'm a psychiatrist at Johns Hopkins. I do a lot of teaching of psychiatry as well as patient care and research, and I'm really happy to be here. Thanks, Gabe.
I am very excited to have you here because you taught me that there is something other than the DSM. Before we get started, we've got the DSM. A lot of people in mental health circles have heard of it. Their doctors have used it. It's either the bane of your existence. Whatever it is to you, it feels like everybody has heard of the DSM, which is the Diagnostic Statistical Manual, and I've probably butchered it, but it's sort of the gold standard for diagnosing mental health issues. Now, Dr. Chisholm, she said, no, there's another way, and that's the perspectives approach. And I immediately said, well, what is the perspectives approach? And not surprising, that's my first question.
Well, it's a good question, Gabe. So the perspectives approach is a different way of understanding patients, and it developed at Hopkins maybe 40, 50 years ago. And it's really based in general psychiatry that's been around for 100 years in Europe, and a way of understanding patients. And it's a way of understanding patients that doesn't just think of patients as having diseases, but is really trying to understand psychiatric problems in all of their complexity. Psychiatric problems occur in people. And so it can be something you have that the DSM is really good at capturing, like a disease like schizophrenia or manic depressive illness, but it can also, the problems can arise because of who you are. You might be somebody who feels things really strongly, who reacts to things really strongly, or somebody that doesn't react to things much at all, which can be a problem in some circumstances. It also can be a problem that's caused by something you're doing. Are you restricting your food intake? Are you using drugs or alcohol in a problematic way? Or it can be because of something you've encountered in your life and the way you're dealing with something. So not everything is a disease, and every disease occurs in the context of a person who has a certain personality, a certain life history, and that's what the perspectives approach helps psychiatrists do, is understand their patients in a holistic way. And so instead of just diagnosing them, giving them a label, it's understanding their problems in a larger context.
When I first heard about this, I thought it was new. I was like, oh, okay, so finally psychiatry, psychology, it's evolving. We've got a new method. But as you said, it's not new. It's been around for 40, 50 years. And that leads me to my next question. If it's been around for so long, why isn't it more well known?
That's a really, really good question. And I often wonder that myself. I mean, there have been over 200 academic articles written about the perspectives of psychiatry. So it is known within psychiatric circles, but it hasn't been adopted. In part, it may be because of the strength of advocacy that's behind the DSM. I mean, it comes out of the American Psychiatric Association, the DSM, and it's kind of a business unto itself. And so it's part of a bigger framework of organizational psychiatry. So that's one reason. I think another reason is that it's very complex, right? It doesn't make things simple. It makes things more challenging for a clinician because we do have to take a very thorough history then, and all of these problems aren't best treated with a pill, so it means actually doing more as a psychiatrist. And so I think it's a confluence of organizational pressures and also what happened in the 80s with managed care, which caused psychiatry to focus more on shorter visits. So I think it's a combination of those two forces, but there are many other factors, I'm sure, as well.
I know that this next question is going to be somewhat difficult to answer because every single patient is different. So I just want to put that right out there into the universe. But one of the things that you said is it takes longer to diagnose, which immediately triggered in my brain, well, how long does it take to diagnose with this approach, and why? What adds on the time?
Yeah, well, I would say that, I want to say it's more than diagnosis. It's really formulating a patient, because diagnosis really says you're kind of categorizing somebody, labeling somebody. And again, if somebody has a disease, it's important to diagnose that disease. But this is more a way of understanding a person's problems and figuring out how best to treat it. And it does take a lot of time because you have to get to know a person. You have to start to understand their affective temperament, their cognitive capabilities, understand their life story, not only their family history in terms of heritable illnesses, but also understanding, what it was like to grow up for them, what kinds of experiences they had, understanding, details of their growing up years, their relationships, their work histories, things like that. So it really takes me about an hour and a half to ask a lot of questions of the patient to get some beginning of an understanding of who they are as a person and what they've encountered in their lifetime. So it does take time up front, but I would say it saves time in the long run because you actually are able to more appropriately and accurately develop a treatment plan for people. So
many of us have been to a psychiatrist and we have that initial appointment. It's usually an hour long. Is that, how long is the initial appointment for the perspectives approach?
Well, I like to have 2 hours with a patient at the first visit. I think most of us do. I have worked in certain circumstances where the resources were limited for psychiatric time, where I would take an hour at the initial visit and then do catch up, get caught up on other information at later visits. But I do like to have a 2-hour block of time because usually the first hour or a little longer is me asking questions, but then I really turn it over to the patient and ask them if there's anything important that they think I should know that I haven't asked them. And also then we discuss my understanding of what they've told me and how that might be contributing to their current problems. I like to kind of have a discussion about that with the patient and get their views on what my thoughts are, and then we arrive at a treatment plan together. So that usually takes about 2 hours for the initial visit. It can be done over several consecutive visits if need be.
As I'm listening to you, I think this is fantastic. I want this. Like, let's do that. It's what I have been up on a soapbox about for probably my entire career. I mean, good outcomes are a partnership between patient and doctor. And it sounds like this perspective has this built in. And I really liked what you said earlier about how, look, we're not trying to diagnose people. We're trying to figure out, what is going on in the patient's life that we can tweak and make better. And like, I'm just like, you're hitting on like every single thing that every patient advocate I've ever heard in the history of time ask for. Once again, I still have to ask, what's the problem? Who is keeping this down? Because it really, truly does seem like what the mental health community, especially patients, have been looking for.
Well, I think it hasn't caught on in mainstream psychiatry. I must say that Hopkins Psychiatry has been ranked #1 in the country by U.S. News and World Report for the last 2 years in terms of hospital departments of psychiatry. So we're doing something right, I think, and hopefully people will be more curious about what that is that we're doing. But I think it hasn't caught on because people think that, the DSM is good enough, or the biopsychosocial model is another sort of competing conceptual model, and people really haven't taken the time to learn about the perspectives. There are a couple of books out on the perspectives. One was written by the co-developers of the perspectives approach, Drs. Paul McHugh and Philip Slavny, and their book is very philosophical. It's very dense. It is not an easy read. It's not even easy for people who are psychiatrists or psychiatrists in training. So I think that it's more, it's very theoretical. We have, about 10 years ago or more now, co-wrote a book with a colleague of mine, Konstantin Leketsos, and he and I wrote a book for clinicians about how to apply the perspectives approach, that more conceptual model, theoretical approach to patients. I can't say it was a bestseller, so not a lot of people perhaps read it, but I think the more that people are hearing about the Department of Psychiatry at Hopkins, the more acclaim it's getting, I think people will become more curious about this model, and hopefully will be willing to try it and see if they don't get better results for their patients with it.
It's very interesting to me as I listen to you talk about, it's developed at Johns Hopkins. That's a well-known, world-famous medical school. I have been aware of Johns Hopkins since I was, I don't know, 10, 11. I mean, it's like Harvard. It's just a very well-known school. And when you talk about it, you're like, well, we over at Johns Hopkins are hoping that it catches on and people realize that we do good work. And I think if you're having trouble convincing the general public that Johns Hopkins Medical School is putting out good work, what hope do the rest of us have? Is this just a case of people digging their heels because, hey, this is what we like and we like it? Because I really just am curious. I mean, if Johns Hopkins can't convince people that this is new and emerging, or that this is 40-year-old research that's good and has better outcomes, it almost seems like every other researcher should just call it a day.
Yeah, well, I think part of that burden is on us, because I can't say that we've really done studies where we've compared one approach to another approach. What we can say is that the people that train at Johns Hopkins who go to other institutions to practice are generally thought of as the go-to clinician, and are able to take on patients who have complex cases that haven't really been able to be as easily treated by the other clinicians. So I do think our clinicians have a great reputation that we train. I just think it requires a little bit of openness and curiosity to do things differently. And I think that, people don't change, right, until it becomes too uncomfortable or painful to stay the same or remain the same. So just like with everything else, change is hard. And I think people are not trained in this way of taking care of patients. So it's hard.
That makes perfect sense. So we've talked a lot about the perspectives approach and how it works, but let's contrast and compare a little bit. How specifically does it differ from the DSM?
Okay, so the DSM is really a tool that was designed for research purposes. It was a way of somebody who was examining somebody with a set of symptoms in England, and if they were seeing somebody in the US with a different set of symptoms, that they could say, okay, we're all agreeing we're seeing the same kinds of symptoms. And so it was developed as a way for researchers to reliably make sure that they were studying the same phenomena. So it has it's in categories. It was designed to be atheoretical, meaning that it wasn't saying that this is a disease or this is a, something better explained by a Freudian theory or something like that. It was meant to be atheoretical, just outlining sets of signs and symptoms. But because it was using a categorical approach, kind of putting people into categories, it implied that these were diseases, because that categorization is the way that disease, classification works. Even though clearly there's some things in the DSM that aren't diseases, like adjustment disorders, for instance, because it specifically says that it's in reaction to this or that. However, it really started to take on this kind of biological model for the most part. And so now I forgot your first part of your question, Gabe. I'm like wandering through the DSM.
I love it. It's a great history of the DSM. The specific question is, what specific differences are there between the perspectives approach and the DSM?
Got it. So okay, so the DSM really is focusing on, for the most part, even though it doesn't say this, for the most part, it's focusing on diseases. So it lists things, and the implication is that these are diseases. So what happens is when somebody takes a history and they ask you about your signs and symptoms of illness, you're going to have quickly be able to fit into one of these categories. Okay, you've got PTSD or depression or something else. And basically that seems like enough of a history. Once you gather the kind of the symptoms that a patient has, if it fits one of these categories, it's sort of like a kind of penny in the slot kind of diagnosis. Okay, you said those things, those are on a list here in the DSM. My work is done, and we'll just treat that problem, which I think is a huge limitation of the DSM, because it's only disease. Thinking of something as a disease is only one way of explaining it or understanding it. And it's, there is an inherent difference in the nature of a condition like schizophrenia, a disease that comes upon somebody unbidden. They don't do anything, it just happens to them. And a condition like grief, where there's an event that occurs, somebody makes meaning of that, but that's better explained as a reaction to something that somebody has encountered. And not that everybody comes to a psychiatrist or seeks any kind of clinical treatment for grief, but it is something that's a psychiatric problem for which some people do reach out for support. Similarly, if somebody has, is somebody who is very present oriented and doesn't think about the consequences of things that they do, it's hard to say, to fit that into the DSM kind of model. And it's not like something that just comes upon them unbidden. That is an interaction of who they are as a person, their affective temperament, and the things that they encounter. And the reactions that they have, either in terms of behavior or thinking, to those, the interaction of their affective temperament, how they feel in certain situations. That's treated very differently than a disease is treated. But if you really are just looking at kind of signs and symptoms, you might say, oh, this person gets very irritable, or this person flies into a rage, and you can misdiagnose somebody as having a disease, or you can think of medications that will help that situation, that those kinds of reactions, rather than perhaps more targeted therapy, like guiding people through life's provocations and helping them understand their own temperament and their own role in those problems. So I just think in order to have the best outcome for people, you have to think about the difference the different origins of these various problems. And the DSM pretty much is implying that most problems' origins in the DSM are diseases for which more that are due to a broken part or a broken functioning, for which a medication is the best treatment.
Understood. So now a question that popped up was, can the perspectives approach diagnose? Now that may be worded poorly. Remember, our audience is not doctors, but can you use the perspectives approach to diagnose, or no?
Yeah, I think that's a really good, actually, I think it's well worded. So, I mean, we think of it more as a way of formulating, which is understanding the origin of someone's problems, and usually there are multiple origins to someone's problems, because even if it's a disease that you're experiencing, that's happening, in you as a person, and you're giving meaning to that. And depending on your personality, that might take on different meanings. So there's interactions between all these perspectives. So the perspectives approach is a way of formulating, and within that formulation, there can be diagnoses given. I mean, we use the DSM because you need to use the DSM for billing purposes, but also because, there are these syndromes, clinical syndromes, a cluster of signs and symptoms that run a course together, like schizophrenia or manic depressive illness or bipolar disorder, that we will use to diagnose. I think some of the quote unquote diagnoses listed in the DSM are a little inadequate. Like, I think adjustment disorder is one that we will use because it's there and we have to, but I would rather understand that as demoralization, rather, or a more kind of complex way of understanding the origin of a person's problems, rather than a diagnosis like adjustment disorder that I think doesn't get to the heart of the matter.
One of the questions that came up is the perspectives approach and the DSM meant to be used in tandem, or in a perfect world would they be completely separate, but we sort of have to use them in tandem? How does that all work itself out at the moment?
Yeah, we use them in tandem. I think that there's some diseases in the DSM that there's some, I don't know, diseases or classifications in the DSM that are more useful than others. And so, but we use them in tandem, and I think they can be used in tandem. I think there's some limitations of some of the classifications there that need more explication that we can give with the perspectives approach. But usually when we're formulating somebody, we will say, we'll go through each perspective. From the life story perspective, it sounds like some of the problems may be best explained by this and that, blah, 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 blah. We go through each perspective, the dimensionals perspective, the personality perspective. We might highlight aspects of that are relevant to the presentation, elements of the behavior perspective that are relevant to the presentation, and then we'll end with looking at how much the disease perspective can explain the current presentation. And so that can be, almost all of the DSM, we might say there's very little relevance of these other perspectives to the person's presentation, and then we might use more or less of the DSM for that person.
One of the things that you said a little bit earlier is that the DSM only leads to medication. Can you talk about that a little more?
Well, I wouldn't say it only leads to medication.
Okay. Thank you for clarifying.
But I would say that once you're implying that these classifications, these diagnoses are diseases, and by using a categorical construct, that's the implication, you then look for ways to cure those diseases. I mean, if you're thinking of a disease as a syndrome that runs a particular course, usually in medicine, the next step is looking for the pathophysiologic process and ultimately the etiology or the ultimate cause. For instance, if somebody has congestive heart failure in the hospital, then you're trying to think about what the process is with the, is it, and where the origin of the problem is. Is it in the lungs? Is it in the heart? Is it, or if somebody comes in with a fever of unknown origin, you're looking for the, ultimate etiology of that problem. There are not many problems in psychiatry that are as clear cut, where we understand the ultimate origin or the pathophysiologic process for that matter. There's some that are very clear. But for the most part, when you're thinking about diseases, you're thinking about remedies. And the easiest remedy to give is a pill or a medication. And so that's, so even with classifications, diagnostic classifications in the DSM, like PTSD, which may, most people would agree has an element of psychotherapy as part of the treatment, there still is this idea of, well, this is, they're looking for medications and looking for perhaps broken parts or what's gone wrong in terms of the person's functioning, for which a medication could be a remedy. In the latest version of the DSM, there's a new entry called prolonged grief. What's prolonged grief? I mean, who knows? To me, that makes no sense to have in the DSM because, everybody's different. It's not a very personalized approach. And I just think that's an indication that we may be going too far in using the DSM and this classification system, when wouldn't it be better to think about this event that this person has encountered in their life? It's happened in a certain setting, a certain sequence. It's happened to a person with a personality that has different ways of coping and reacting. Wouldn't that be a better way of explaining it than having it be a diagnostic category? That's been my experience, is that once things get into the DSM, into these diagnostic categories, that medication isn't far behind.
Now we have a thank you so much, audience. I know we have several questions. Some of them we can answer, some of them we can't. But there is one that I'm going to shift ever so slightly, and it says, how often does an inability to read or do classwork play a role in how some children are pushed to certain diagnoses like ADHD or ADD? Now, I'm guessing that you don't know the percentages or the numbers off the top of your head, but one of the things that struck me in this question is you talking about the perspectives approach versus the DSM. And in the perspectives approach, if I understand correctly, you would find out why they have the inability to read or to do classwork. Can you talk about that?
I love this question. So I work a lot with young adults, and many of them have ADHD. And so I've thought about ADHD a lot. And this is a great example of how the DSM's classification system has pushed ADHD, pushed our thinking about ADHD into disease reasoning. I really wonder about this. So the way I would see ADHD from the perspectives approach is that this is a cognitive, so the perspectives approach has this, it's disease, behavior perspective, life story perspective, and dimensional perspective. And dimensional perspective refers to personality. And there's two parts to personality. There's cognitive potential and affective temperament. And the whole idea about the dimensional perspective is that it's looking at measurable, universal, graded traits. And so IQ is the classic example. It's graded, it's measurable, and people vary. If you think of, it's controversial, the bell-shaped curve, but you think about that. Or for a physical trait, the analogy would be height, for instance. Everybody's somewhere on this dimension of height, and there's an average, and then there are people that are below average height, above average height. Same with intelligence, below average intelligence, above average intelligence, but everybody's somewhere on that scale, on that dimension. And the same, I think, is with executive function or frontal lobe ability, which is really what ADHD is primarily about. How able someone is to inhibit impulses, whether it's impulses to move or impulses to pay attention to something that, other than what they're supposed to be paying attention to. But there's an inability to suppress these impulses, and that has to do with where you are on this dimension of frontal lobe ability or executive function. And so with the dimensional perspective, the conceptual triad that underlies that is that you have a potential on this, you are someplace on this scale of, low executive function to high executive function, say. You are, and that potential interacts with a provocation. And the provocation could be being in a classroom. And then you have a reaction, which could be, running around the classroom, flying into a rage when you're told to sit still or whatever. I think this ADHD research has really shown that, I remember the study from, it must have been 30 years ago, where they had kids and they had them in an MRI scanner, and they were asking them to do a math problem. And it was a boring math problem. And, they could get the kids' frontal lobes to improve if they made that math problem more salient, or they incentivized the kid. And they could, so if they said they were going to pay them money afterwards, or if they made the math problem more interesting, they could get the frontal lobe to light up. Or if they gave stimulant medication, they could get the frontal lobe to light up. So there's, I guess to me, that's a way of saying that it's not all disease, that it's, or maybe not disease at all, that ADHD, in my mind, is best considered as a dimension, and people have a potential for executive function, and it meets a provocation, a boring classroom, too many rules to sit still or whatever, and then there's a response that is problematic. So I think thinking of ADHD specifically as a disease really says the main solution is to give medication rather than to help somebody understand their potential and or guide them through the provocations, or change the provocation so it's it isn't causing problems, making the classroom more interesting, for instance, giving people time to run around or whatever.
Thank you, Dr. Chisholm. No, I feel that it's probably important to say that if you're watching this, don't run and take your children off medication, or work with your doctors, you're not saying that 100% is.
Oh,
yeah.
No. I'm not saying that medication can't be a useful tool for ADHD, but I'm saying thinking of it only as a broken part or broken function, I don't think that's the best way of understanding it. Because even things that are actually best understood from the dimensional perspective can sometimes still be helped with medication. The people with severe personality disorders benefit from medication, and that's clearly a dimensional understanding personality. So yes, absolutely. I'm just saying that it's in my mind best understood as a problem that is it is best explained using the conceptual model of the dimensional perspective rather than the broken part model of the disease perspective.
Wonderful. Thank you. Thank you so much for clarifying. Once again, audience, ask away. Ask as many questions as you want. Dr. Chisholm is awesome and will answer as many as she can. Now, we have a longer question. There's actually two questions here. Let's focus on the first one. And once again, if it's out of our scope or out of our range, just let me know and I'll bop it away as fast as it appeared. But do you feel that it's important to consider the positive impact the role complementary care has in holistically caring for individuals? Just focus on question number one.
Yeah, so complementary care is a big field. I would say that I want to understand what's worked for people and and be open to working with each patient to understand what's worked for them or what they think might work for them. And as long as there's no contraindication to engaging in, a complementary treatment, I think that, I would welcome any solution to help my patients. So I do think it's important in the holistic care of individuals to understand the full range of treatments that are available, of therapies that are available.
Wonderful. Thank you so much. We have another question that I'm doing my best to type in as fast as we can. And the question is, so you can get started on it, is how do we find a doctor who uses the Perspectives method?
It's a really good question. And so at Hopkins, we've trained hundreds and hundreds of clinicians, of psychiatrists. They're all trained using this model, or they have since late 1970s. So there've been, a generation, maybe a generation and a half that have been trained using this model. So they're out there, they're all over the country. And we have a website. If you go to, I think it's Hopkins Medicine /Psychiatry, you can get to our website. And on that website, there's ways to reach out to ask for referrals. We're actually building a special site. It should be up in about a web page in about a week that will actually have a list of the Hopkins trained psychiatrists by geographic region. Right now, it's more through specialties. But I think that having that list of people trained and where they're practicing, which states they're practicing in, will be a really huge resource. But anybody who's trained at Hopkins in the last, 40 years has been trained in this method.
Wonderful. I tried to do a quick, here we are. I tried to do a quick search for the website. If you search for Johns Hopkins Perspective Approach, you get a wealth of information, including that guide. And Dr. Chisholm, your name is all over it. It's almost like you've been on the front lines of this for a long time. Now, who came up with this? I mean, a little bit of history. Like you said, it's 40, 50 years old. So who invented this method? I mean, what's sort of just the history? Take us back 50 years ago.
So it's not really an invention. It's more a translation of really, the idea was, this is developed by Paul McHugh and Philip Slavny. Paul McHugh was our department chair starting in the mid-70s. Philip Slavny was the residency director. They came together from Oregon. And, they basically were thinking about what psychiatry needed. And at the time, this was in the 70s, there was, there had been sort of this, there was this tension between the psychoanalysts, basically, the majority of department chairs in psychiatry in the 60s and 70s were psychoanalysts. So there was this whole kind of feud, if you will, between the psychoanalytic tradition and the emerging quote unquote biological psychiatry movement with the advent of Thorazine and other medications. And it was causing a lot of conflicts. And so they thought, well, let's get away from these conflicts and instead just look at what psychiatry needs in terms of a model of understanding the origins of psychiatric illness. And so they really just made explicit what psychiatry knew implicitly, which was that psychiatric problems vary in their natures. There are things like diseases. And for that disease perspective, they drew a lot on obviously the medical literature and the scientific, I guess, biological sciences evidence. And then, so that's the, diseases, something like a disease like schizophrenia, very different from other psychiatric problems like grief or eating disorders for that matter, or sexual disorders, or personality disorders. And so then they started looking at the evidence from the psychological sciences about the things that some of these other psychiatric problems had in common. And so then they developed this other way of looking, besides the disease perspective, this other way of looking at people in terms of their dimensions, as I've described, where they are in terms of their cognitive potentials and where they are in terms of their affective temperament potentials. And then the life story perspective, that personal, the meaningful explanations that people give to events that they've encountered. And then the behavior perspective, which is one of the most interesting to me, because it really is, it's fascinating to me how these illnesses that seem so different, like anorexia, nervosa, and substance use disorder, they look very different, but they actually have so much in common. And so they think of it in terms of the behavior perspective. There are these innate behaviors that are behaviors that are designed to sustain our life and the species, that relate innate behaviors like eating, feeding, sex, sleep. And then there are these acquired drives or behaviors like substance use disorders or self-cutting, things like that, that basically hijack this other underlying neurocircuitry of feeding and sleep and sex. And so they have these things in common. Anorexia nervosa and substance use disorder seem very different, but they both involve, at least initially, an element of choice to restrict one's food intake because of fear of being fat, or to try a substance. And then with that exposure to the restricting or the substance, people get conditioned. They like what happens, right? They either like the euphoric experience, or they like losing weight, or getting the compliments about losing weight. And then that drive to engage in the behavior, say restricting or using the substance, increases. So the drive increases, and as the drive increases, the ability to choose not to engage in the behavior decreases. And then, the conditioning is still going on, and the drive gets stronger and stronger. And then you get, in these severe states of anorexia with severe, weight loss, and severe states of substance use where people are using to the neglect of everything else in their life. So these two illnesses that look so different on the surface have so much in common in terms of the origin of the problems. And the treatments that are available are actually very similar. You either do things to decrease the drive, or you do things to, through reconditioning or interrupting that cycle in some way. And you can use medications to do that as well as therapy, which is kind of a point that relates to that ADHD question. Just because something is best understood or best explained from the dimensional perspective or the behavior perspective doesn't mean that medication can't be a part of that. But understanding the conceptual differences really helps understand how those medications are going to be used. It's not going to be used to cure something. It's going to be used to, say, in the case of substance use disorder, to interrupt the behavior of using the substance by, giving say, an opioid agonist like Suboxone, buprenorphine, or methadone, so that somebody can break that cycle of seeking out the drug.
Thank you so very much. Now I know we're almost to the end. We have a few more minutes. Do you have any? Oh, let me. There we go. I hit it.
So now you understand why the perspectives hasn't caught on as well, because it takes a long time to explain each one of these questions. I feel like it, took a long time to explain adequately. So
I think though the thing is one of the things that you said at the beginning was that it takes a little bit longer in the beginning, but it saves you time later. And I think of every single time my parents yelled at me. They're like, well, if you don't have time to do it right, how are you going to have time to do it over? They're like, well, do it now or you're going to be here all day doing it again. Or just, even in my work life, I'm like, well, if I build this foundation, the rest of it's just going to shoot up, no problem. And as a man who lives with bipolar disorder and as a mental health advocate, I see all these people, the revolving door, we talk about it constantly, and all these people who can't get care, and the shortage of psychiatrists and psychologists, and on and on and on. And I think, well, if we could get people to reach recovery, they'd remove themselves from the system, and then the system wouldn't be so burdened. And it sounds like that's what you're saying, right? It is more work up front, but it has better outcomes. And
exactly. I mean, I think unless you understand the nature of the problem, you don't really have a way of designing a treatment that's going to adequately respond to the problem. For years, people were searching for a broken part or a broken function in the brain for anorexia nervosa. That led nowhere. But understanding it as a behavioral disorder that that has conditioned learning, drive, and choice, and interrupting that some aspect of that cycle, that's the kind of treatment that's going to result in a good outcome.
Excellent. Thank you so very much. Do you have any final words on the perspectives approach before we close?
All I can say is it's not rocket science. It does take some time to wrap your head around it, but it really is if you think it, to me, it's more common sense psychiatry. I mean, it's common sense to see that there's a difference, and AA recognizes there's a difference between alcohol use disorder and schizophrenia. There's an inherent difference in those two illnesses. They're treated in different ways. Nobody says, the treatment for schizophrenia doesn't involve going and saying, one day at a time, or, I'm making a choice not to use today. We know that these illnesses have different natures, and unless we design treatments in recognition of those different natures, I don't think we're going to make progress. So it's common sense. It does take a little bit of a shift of understanding, but I think it will be worth it in the long run for people.
Well, I could not agree more. It's what mental health advocates have been asking for so long, and I can't believe it was right under our nose the whole time. Hopefully, this will shift some advocacy to start talking about this, Johns Hopkins approved, research, known, made method that, when people say, well, what do you want us to do? We can finally say, well, we want you to do this. I think it's a much bigger and louder and bolder and better rallying cry than we don't like the old method. What do you want us to replace it with? Something better. So I hope we all do our homework and we all learn a lot. Dr. Chisholm, thank you so much for being here.
It's my pleasure, really my pleasure, Gabe. Thank you. And thanks
you-
everybody for your questions.
You are very, very welcome. All right, everybody, you know what I'm going to say. Join NAMI Tennessee's email list so that you don't miss out on great events like this. You just go over to namitn.org and sign right up. It's absolutely free. We send like one a week and remind you not only of things like the NAMI at Home Facebook Lives, which happen every Monday at 2 Central, 3 Eastern, but also legislative advocacy, conventions, free programming, support groups. I mean, just everything that NAMI Tennessee does comes out on that super cool curated email, and you don't want to miss a thing. All right, everybody, we will see you next Monday at 2 p.m. 2 p.m. Central, 3 p.m. Eastern. Bye, everybody.